Yes, I am director at Advanced Radiation Oncology Department in Italy, Negrar-Verona, Ospedale S.Cuore in Calabria, and I'm also a professor of radiation oncology at the University of Brescia. These are my disclosures and conflicts of interest. And I would like to start with this slide. As you know, in modern radiotherapy, IMRT and similar technology able to obtain an optimal dose distribution is the standard of care in terms of increasing the dose on the target, minimizing the involvement of surrounding organ at risk. And daily IGRT is another milestone, very important, because in our Linux, conventional Linux, we have this kind or better images that can allow us to check, control, and optimize the positioning of the patient and the anatomy of the region of interest, especially in prostate cancer. However, we can say that thanks to MRI, having MRI on board, we can do another step forward in the improvement of quality of treatment, especially with real-time imaging during the session. And we can, as you know, recognize in the market two kinds of machine. Both are equal in terms of possibilities to perform an adaptive treatment. Elekta Unity, that is the machine of my department, of my experience that I'm sharing here, as a 1.5 Tesla MRI on board. And thanks to this MR, we can really have a very high quality of imaging on board, especially important for soft tissues in the pelvis, including prostate definition. This is only a view of our experience. We started in 2019, and up to September 2025, we treated more than 1,450 patients with more than approximately 12,000 fractions, with a median number of fractions that is 5. And you can see that most of the patients were treated for prostate cancer, most of them in 5 sessions. So SBRT is one of the most represented treatment in using MR-guided adaptive daily approach. And another intriguing thing is that even if this approach is very complex, because we have to perform every day the MRI with the new contouring, new plan and delivery, the treatment is up to 38, 40 maximum minutes. And in most of the cases, we are able to perform adapt to shape. It means that we are really replan day per day the case of the patient. Here you can see some aspects. This is from fraction 1 to fraction 4. You can see how bladder can change, how rectum can change. And these images are very important to understand how, without this approach, we have to maintain larger margins, or we could have some uncertainties regarding dosimetry every day. And this is an example from 1 to fraction 5, how prostate can change a little bit the position based on a empty or full rectum and empty or full bladder. So even if we have different situation regarding the anatomy every day, as you can see here, the bladder is not full in this case, or is more different in another. If we are able to achieve the correct dose distribution, we can perform the plan of the day. And this adaptive approach, I think that could be important to minimize uncertainties. As you know, rectum is one of the most important in terms of uncertainties related to the daily changes during the treatment. This is a paper that we published some years ago regarding our first report of the first 25 patients recruited and treated with this technique, demonstrating that if we compare the quality of life before and after the treatment, this approach was very safe and well tolerated. And this is another paper of my group published in Green Journal in 2023, where we demonstrated that prostate can change the dimension. Evaluating MRI on board every day, prostate swelling was present in the half of the patient, while a shrinkage was present in 11%. It means that we could have some changes that also with conventional treatment can affect the precision of our approach. This is a review. I like a lot this review. Also, a part of my patients were included in this review, systematic review and meta-analysis that demonstrated that the approach, SBRT, MR-guided approach, compared to conventional CT approach, was significantly in favor of a reduction of acute grade 2 or more GU and GI toxicity. Specifically, GU was reduced by 44% and GI 60% compared to COM-BEAM CT-based SBRT. It means that adaptive and the guidance of MRI can for sure help minimizing the uncertainties. Here you can see the report of the first 1,000 patients treated in my institution. Most of them were prostate in 5 sessions, as you can see here. Most of them were treated also in consecutive days. And you can see also the timing was very minimal, a median time of 33 minutes to perform the entire procedure of adaptive MR-guided approach. And I was very happy in 2023 because my center was one of the first worldwide centers to test the CMM system, the system to manage the movement in order to interrupt the delivery if the target is outside the region of interest. Demonstrated also here that the duty cycle, the entire timing, including the uncertainties, was a timing absolutely acceptable for our patients. And here you can see in this video how we can check during the session the impressive changes on rectum volume. And here you can see how it's possible to interrupt the delivery of our fields if the position of the rectum is not properly as expected. Here another image demonstrating that only 5% of the cases had a treatment more than 1 hour using comprehensive motion management, demonstrated that the median room time is 36 minutes. And here you can see another confirm that the toxicity with this approach, SBRT, most of them were prostate in 5 sessions, was absolutely optimal, no grade 3 toxicity in 1,000 patients. And here you can see the most represented symptom, urinary obstructive symptom, G1, G2, and G3. And you can see the late toxicity, G1, G2, G3, and also here no greater than grade 3 were reported. This is in line with what we reported before. This is the report of the first 100 patients treated with this approach, only prostate, only in 5 sessions, demonstrating only 1 case of grade 3. And what is the future regarding this technology? Of course, we are going to a better preservation of some structure, including the sexual structures. For example, the neurovascular bundle, we can see the structure on MRI and we can exclude, as well as the urethra, these structures from high doses. Or here you can see that we can define better in MRI on board the dominant intraprostatic lesion to perform treatment as well as hypoflying schedules in 5 sessions, increasing the dose where it is really necessary, but at the same time preserving the surrounding organ at risk, maintaining the dose distribution as we necessary. And here you can see another scene MRI, the movie of what can happen during a session. This is another advantage compared to COM-BEAM CT because we can see in this way, second per second, the treatment in real time, and the machine is able to interrupt the delivery when there is an unexpected movement. Another endpoint is to reduce margin. We activated an ethical committee approved protocol with a progressive reduction of the margins for prostate, obviously in 5 sessions. And the gold endpoint is to arrive to 1 millimeters. This is a case in which we applied it directly 1 millimeter, but was a ray radiation. In fact, as you know, prostatic ray radiation is another important frontier of modern radiation oncology in prostate, and this is a paper that was published a few years ago that is a consensus for the ray radiation approach in pelvis tumor when MRI, obviously, and some aspect that can help us to argument the precision are really important. This is the experience of some irradiation that was published from my group a few years ago. So I can conclude saying that MR-guided approach is a concrete available option in several settings, including prostate cancer. The advantages of MRI over cone-beam CT are visible, especially in soft tissue. The capability to adapt is robust. The capability to check and control the delivery is important by real tumor tracking. So we can also go to new frontiers, including new indication, as well as ray radiation. And after an experience of more than 1,000 patients, for sure, it could be one of the best approach to obtain an augmented treatment in prostate cancer, especially when SBRT is the preferred approach. Thank you for your interest.